Welcome everyone again to another episode of the ideaXme show that profiles the humans behind the really big ideas that are shaping our world, inspiring future creators, and offer those really great stories. I'm Ira Pastor, your health, aging, and longevity ambassador along for the journey. So, as you know, on the last several shows, we've been spending a lot of time talking about different components of the biologic architecture of life and aging, spending time on the level of the genome, the microbiome, systems biology. All very fascinating topics. However, as I point out, we can't forget that when these processes ultimately go awry, things go wrong and trickle down to a wide range of chronic degenerative disorders responsible for human suffering and death, and a very large $7 trillion healthcare figure around the world nowadays. And one of the major sets of pathologies that are still responsible for a major part of that figure in 2019 remains the basket of diseases that encompasses the term arthritis, of which there are literally dozens of different types currently classified. Arthritis is a general term meant to mean any disorder that affects the joints negatively, and the most common forms being osteoarthritis and rheumatoid arthritis, where symptoms generally include things like pain, stiffness, redness, warmth, swelling, and a decreased range of motion. In some types of arthritis, on the autoimmune side of things, or other organs in the body can be affected. 2018 CDC data estimates in the United States around 55 million people suffer from one form of arthritis, and that estimates in about year 2040, that's going to be up near 90 million. No known cure for either rheumatoid arthritis or osteoarthritis today. Treatment options vary widely depending on the type of arthritis, include things like physical therapy, lifestyle changes, weight control, exercise, bracing, and various medications, which ultimately help to reduce inflammation in the joints, and in the case of autoimmune diseases, immune response, which can ultimately help decrease pain and potentially slow the rate of joint damage, hopefully to zero, which is the current nature of a class of holy grail-ish type drugs in the rheumatoid arthritis space known as DMARDs, or disease-modifying anti-rheumatic drugs. There are not, as of yet, any drugs that are on the market that are currently classified as disease-modifying osteoarthritis drugs. However, whether one is looking for that or one is looking beyond the current state of the art in rheumatoid arthritis, I think many people would agree that that next holy grail point will have something to do with the stimulation of chondrogenesis, or the process in which new fresh cartilage is created in the joint, ultimately reversing the pathogenesis as opposed to just slowing or stopping it. Once damaged in humans, cartilage is very recalcitrant to repair and regeneration. There are issues with regards to the way chondrocytes can migrate, blood flow in the joint, deposition of new matrix is a very slow process, scar tissue forms quite frequently. But this is not the case in other species, such as newts, zebrafish, other regenerative organisms which can regrow cartilage and remodel it perfectly throughout a lifetime. Today's guest, who I'm very excited to have with us, is going to take us further into these themes, and that is Dr. Byers Kraus. Dr. Krause has both an MD and PhD from Duke University and is currently professor of medicine, pathology, and orthopedic surgery, and a faculty member of the Duke Molecular Physiology Institute at the Duke University School of Medicine. She's a practicing rheumatologist with over 20 years of experience in osteoarthritis research. Dr. Krause is the past president of the Osteoarthritis Research Society International, which is the premier organization focused on the prevention and treatment of osteoarthritis, the promotion and presentation of research, education, and worldwide dissemination of new knowledge. In 2019, she was elected to the Association of American Physicians and awarded the Lifetime Achievement Award by the Arthritis Society International. She's the co-PI of the Foundation for NIH Osteoarthritis Biomarker Consortium project, which advances the validation and qualification of biomarkers for osteoarthritis diagnosis, prognosis, and clinical trials. She also directs the Duke Biomarkers Shared Resource, which is a facility that assists investigators with the design and implementation of molecular and protein assays to evaluate with biochemical and inflammatory biomarkers of the disease. And she's also the director of the Molecular Measures Core of the Center for the Study of Aging and Human Development. All that being said, Dr. Byers, thank you so much for coming on the show today.
Ira, thank you for that wonderful introduction, both to arthritis and to my CV. I think that, what you described is, in a nutshell, a big, big problem in a very succinct way. So it'll be good to and fun here to be able to talk a little bit more in detail about different aspects that you think folks might be interested in.
Excellent. Excellent. Appreciate that. Typically, we start off by giving our guests the floor just to talk a little bit about themselves, your background, where you grew up, how you developed an interest in science, in medicine, and ultimately why you were attracted to orthopedics and have spent time building such an amazing career in the space.
It's not often that one gets to tell about their childhood. So that's always a fun trip down memory lane. I was always interested as a child in making things. And it started off with more arts and crafts types of things. I think I was the queen of potholders and could make, and tried every different material and type of loop, et cetera, et cetera. But that evolved into the same personality, I think, was carried through all the way because I love doing things in a practical way at the bench, building, making, investigating. And in in high school, I was involved in a lot of science fairs. Really enjoyed that, and I tend to be somebody who kind of keeps a neat office, not terribly, overly neat, but I remember trashing my bedroom because I was working on a science fair project, and it was a disaster for about a year, studying whether it was better to burnish, polish, or leave untouched the amalgam that makes, fillings in the teeth. So that's kind of how I got started. And then in Brown University, they had a wonderful program where you could really make your own sort of career, university career. And so I did a project looking at schistosome worms and kind of modeled them and the flow across them to see how that might affect their nutrition. And it required using big, tubes and lots of motor oil, which then trashed the lab. And the mentor and I had a great time and learned a lot. The director of the department wasn't too thrilled when he would visit and see the straw all over the floor and oil. But anyway, it was that kind of interest that I think is what I carried through. And I like to tell the people in my laboratory that being a scientist is like being a master chef. If you can get to know your ingredients and how they might work, then you can combine them to make something new. And that's what we're striving for, is to become master chefs in the laboratory to investigate, in this particular case, osteoarthritis.
Excellent. I mean, that's a wonderful background, and I love the analogy. Just thinking about that, and sort of that old adage that obviously you got to clean up the lab, but a messy lab and a messy desk is a sign that there's important things going on. Your laboratory is very focused on I'll call this continuum of the pathogenesis that is osteoarthritis. You're looking at the most prevalent form of arthritis. It's a major cause of disability around the world. You look at diagnosis and prognosis and looking at different interventions. And when one thinks of the joint, they don't think of actually always come to mind about sort of the sophisticated stuff, just the combinatorial types of things that are going on there in comparison to other organs. The joint is a very unique place. There's all sorts of, as you point out on your website, different stressors, things going on with, extracellular matrix building and degradation, wound healing dynamics, inflammation, senescence, and on and on. And it's really a very complex place. And one of the main areas that you focus on is this area of biomarkers and really understanding this really complex, I'll call it, ecosystem of the joint, whether it's building stuff up in the joint or whether it's the degeneration process. Can you talk a little about the importance of this part of the work? Because I think it's extremely important people understand why we need good biomarkers when we're going after obviously new treatments, but really understanding a disease like this.
And what you said about the ecosystem is a beautiful term for it. For a long time, people thought the joint was very simplistic. and either thought it was mainly a cartilage, thing or a bone thing. But now people refer to it as an organ.
Mm-hmm.
And organs are complex and they have multiple components. And there's a lot of crosstalk across those components. And as you said, there's an ecosystem. And until we really realized that, we weren't looking at it in enough of a holistic way to make advances. And one of the ways that we get incredible knowledge about what's going on is through biomarkers. And one of the incredible ways that we can develop drugs to treat a disease is through biomarkers. The studies have shown that you're much more likely to be able to advance from the early stages of drug development all the way to an approval for a drug if you have a biomarker that can help drive your knowledge and give you good feedback as to what you're actually doing with that drug. So I think with that knowledge, it's really become a new era in terms of biomarkers. And also those advances have come with the prospect of doing molecular biology, because biomarkers are usually based upon molecular markers.
Mm-hmm.
So in this case, a lot of them are components of the cartilage itself, or even of the interface between the cartilage and the bone, the calcified cartilage. Because the interesting thing about cartilage is that it has no blood supply, it has no nerves, and it has no lymphatics. So it can be deteriorating without giving the usual signals of ouch or, warmth or redness or any of those signals until it's so far gone now that all of the other tissues of the joint organ now are reacting, giving the feedback that there's something actually going on. So the biomarkers of cartilage degradation in particular can be crucial in understanding and identifying that there's an abnormality early on before there's much in the way of symptoms or potentially even any symptoms.
Sure.
So sometimes I like to draw people's attention to the whole paradigm of osteoporosis.
Mm-hmm.
So in the paradigm of osteoporosis, you have thinning of the bones.
Mm-hmm.
Tends not to be a painful condition until suddenly there's a fracture of some kind. Either the person has a minimal fall and fractures their hip, or their vertebra of their spine is crushed because the bone is so thin. But they'll have this decades worth of completely silent process. And nowadays, we know how to recognize that using a bone density test. And when people get to a certain level of thinning of the bone, they'll actually get good medicines to prevent that and build the bone back up. My hope is that someday, with the appropriate biomarkers identifying the risk state, that yes, you're on this early arthritis trajectory, we could then intervene even before the symptoms. Right now, that's not the paradigm. Surely where we want to get to, because by the time we get to the stage where the person has the x-ray changes, that's actually quite late. Sure. And what's the prospects for repairing all of that damage that is already accumulated?
Sure.
So biomarkers are going to be one of the best ways we possibly could have of not only fueling a positive clinical trial and giving good feedback as to whether there's been a good effect, but also moving into this other whole realm of thinking that it's a long, silent disease process, osteoporosis, or even in some cases like heart disease. A lot of people will have silent heart disease, which we are clued into by a high cholesterol and start to worry.
Right.
If we could have those types of clues that only biomarkers could provide, we would be in a much better place to prevent this major disabling condition.
Fascinating. Thank you for that. That's a very elegant overview of the importance, and it's nice to see you're sort of taking this really holistic view towards, as you were saying, looking at it as an organ, which it's really what it is. It's such a complex place. Further along those lines, talking about sort of the biomolecular dynamics that are going on. You recently, generated a lot of excitement. A paper came out. It was entitled "Analysis of Old Proteins Unmasked Dynamic Gradient of Cartilage Turnover in Human Limbs," where you were looking at different combinations of proteins and microRNAs in various joints of the body, and you were finding a really fascinating, pattern where, not all the cartilage in the body, where you were looking at, I guess, different areas in the legs and the hips and the ankles, are all the same. In certain areas, it was much younger than, in the ankle, than it was in the knee, than it was in the hip. And aside from that finding, which is fascinating in its own right, you made some really interesting connections to, we were talking earlier about some of the species that do regenerate very well, the newts and the salamanders and the zebrafish and what have you, where they regenerate in this very interesting, this proximal distal dynamic where, further right, when something's amputated, there's certain different degrees of regenerative capabilities. In humans, we normally think of it as being really very close to the tips, but you're really finding some very interesting new dynamics that we didn't know existed in complex tissue like the cartilage. Can you tell us a little bit more about the work and why you were so excited about this? Because it really is quite fascinating.
Thank you for the opportunity.
Yeah.
So one of our co-authors, Patrick Uniford, who's a proteomics expert in Sweden, he had done a really nice study where he had gotten, at the time of surgery, different cartilages from all over the body, the human body. And he showed, I think to the amazement of many people, that cartilage isn't one single type of tissue. Every place in the body, it seems to have nuances of differences to, now it makes sense, to accommodate the function that it has to, provide.
Sure.
So that was the first knowledge that all cartilage is not the same. That underneath you have some shared components, but each one is quite interestingly different.
Mm-hmm.
So we really were interested in this whole thing that we were trained to understand, which is that the collagen that you're born with is the collagen that you die with. In fact, Alice Marutis, who's a researcher in this area, now retired, had done some fascinating work where she showed that the turnover half-life of collagen in the cartilage was 117 years. So it would suggest that once the cartilage is injured, it's done for. It's not going to repair itself. It's gone. That's it. 117 years is how long it takes, and that's basically your life. Wow. So we were really interested in understanding what the turnover and the half-lives were of the different components of cartilage. Mm-hmm. If we could understand how that component was working compared to all the other components, because there are hundreds of proteins in cartilage.
Sure.
So we set about doing a proteomics experiment with Patrick, our colleague, and looked at the knees and the hips. And we also looked at chemical modifications of the proteins, which you can do by proteomics. Mm-hmm. To our amazement, we found that in general, the hip had accumulated a lot of protein modifications that the knee did not accumulate, suggesting that there was a very big difference in the turnover of the proteins in the knee compared to the hip. So then it sort of piqued our interest. Is this also generalizable to the ankle? So we got some waist surgical specimens of the ankle, and there, to our surprise, they had the youngest proteins. So even we're talking about older people, right? Proteins in the ankle were turning over and regenerating and repairing at a robust rate because they were not accumulating those chemical modifications that were intermediate in the knee and that were high in the hip. So that's why we say you have got young proteins in your ankle, middle-aged in your knee and old in your hip because of the protein modifications that just accumulate just with time. And then we really, for several years, were contemplating how could one explain a gradient effect like this. Mm-hmm. It's not that they're all the same again. Again, it's another example of how the different locations are different. And we came to find out that salamanders can regenerate the distal part of their limb much more robustly than they can the proximal if they have multiple amputations. So that was the reason that we started to look into regenerating organisms as for clues to explain this. And we found a beautiful paper from 2016 where they looked at the Mexican salamander, the what's called bisher, which is a freshwater African fish, and the zebrafish. And their hypothesis was that if they could find something that was common to all of those three organisms that had evolved separately over millions of years, they might be clued into what are the master regulators of limb regeneration. What they reported were 108 microRNAs that those three animals share that control the limb regenerating process. So we thought that would be a good place to look. So we picked the top one and two others from that list and were just elated to see they were high in the ankle, they were intermediate in the knee, and they were low in the hip.
Okay.
So not only did the human make them, but they made them in a gradient. And then we could look at the association of the amount of those with the amount of the protein and the chemical modification, and they correlate very nicely. So they seem to be master drivers of repair type regeneration in human cartilage, whereas in the limb regenerating organisms, they're actually fueling a whole limb regenerative program with the other many microRNA. So we don't know how many of those conserved microRNAs that we have. We want to look and see how many more do we. Our suspicion is that we don't have all of them. Otherwise, maybe we could be regenerating a limb, or we have something that's inhibiting it in some way. Because as you mentioned, we know that children, human children, can regenerate distal tips of their fingers if they're amputated. So, and then that seems to wane that particular capability. So there must be something that turns off that minimal capability that we do have. So that's what we refer to as our inner salamander capacity. We seem to share something with these limb regenerating organisms that is also tied in with the repair response in human cartilages.
You know, as mentioned earlier, you are also the director of the what is called the Molecular Measures Core in the Center for the Study of Aging and Human Development. And it says its tagline, understanding the means to optimize whole person reserve and resilience through analysis of molecular factors indicative of cellular and tissue level ability to withstand and recover from stressors. This is another fascinating area personally to me, because the concept of resilience is one that I don't think many people appreciate as much. They usually think sort of biological fitness, but the whole principle of resilience and this ability to bounce back from stuff when it happens to you, as opposed to just staying healthy, is an extremely important piece of the aging puzzle, in my opinion. Can you tell us a little bit about what your work? I mean, is this heavily still focused on the osteo work, or are you looking at multiple different organ systems? What's going on in the aging front at Duke that you're in charge of?
In the context of our aging center, we really have a very wide expertise. And okay, ours is focused on osteoarthritis, but we have researchers who are focused on the immune system with aging, cognitive performance with aging, physical performance with aging. And so we just have a host of really spectacular researchers. And maybe about 5 years ago or so, our center switched from thinking in terms of things like frailty to switching and looking at the other side of the coin, which is to think in terms of resilience. And although those two things may be somewhat related, they are actually a different way to look at the world. And so we decided maybe what we should do, because we're really interested in trying to promote health and longevity and health span specifically. If we could look at the resilience aspect of it, maybe then we would be more successful at finding things that we could then do to actually promote that. So we completely changed our thinking. And Since then, several of the individuals in the Aging Center have done some spectacular work where, for instance, looking at a whole host of biomarkers, some of which we generate, others of which are generated by a couple of other labs at Duke, to put together a way of profiling people. And they came up with a thing that they refer to as a resilience score that looks at the person for their age. How would you expect them to respond to a particular stressor like surgery? How should they do on average? Do they do better than average? Do they do worse than average? So you can give them a score relative to other people their age. And then look at a host of things that are profiled, including microRNA, and determine if there are any factors that actually could predict those individuals that are more likely to have a positive response, a more resilient response to the stressor, or a less resilient response. And we've come up with a smallish list of things that seem to really be strong determinants of resilience to a stressor. And so, in fact, we just met today. We're trying to now plan for the next study, which is funded, which is to look at people before and after a hip replacement to try to validate those measures. Because if you can figure out who is at risk, then you can intervene sooner. And you might be able to, knowing those pathways, figure out how to actually intervene. And what do those pathways tell you about what's the abnormality? Because oftentimes you can't differentiate those individuals in any other way. You just put them their same age. You can't predict by using, a lot of the usual things that we do. Of course, age is a factor, but given the age that this is a way to sort of unmask people's inner resilience or identify the people who are at risk. Right. It seems to be able to do that. So that was it. I would say we completely changed the paradigm in terms of how we are thinking about aging and how we want to tackle this issue to try to promote healthful aging. And have been making a lot of wonderful advances.
Excellent, outstanding. Take us out, if you would. We have long lead times and so forth in this industry, but take us out a decade now. What are you most excited about in terms of the translation of your work? Are you envisioning small molecules, antibodies, stem cell therapies? Where is that disease-modifying osteoarthritis blockbuster? What's it going to be? The stuff they think from you, like, where's it going to be in 10 years? Tell us what you see on the horizon.
That's just a great question, Ira. Of course, we're not doing it fast enough to suit any of us who are all aging. But now with this, knowledge of this relationship to the limb regenerating organisms, I'm really hopeful that a lot of people are going to be as intrigued by that as us, and that will help to fuel, breakthroughs faster. But definitely what we see as a next step is to be able to test microRNA either singly or in combination in animals that get osteoarthritis spontaneously, like a pig who gets osteoarthritis that looks very similar in their knee to human osteoarthritis, or after injury. Because we know, for instance, after severe joint injury, young people who have an ACL tear have a 50% chance of osteoarthritis within just a few years. And so now they're facing at a very young age a really recalcitrant problem, because no one wants to be, replacing a joint at that age, because then they're going to be looking at several joint replacements. So we think that this kind of a strategy of boosting the natural repair response with a natural innate molecule may be a great advance.
Sure.
I'm hopeful that it may not have as many off-target and adverse side effects, because it is sort of promoting the internal repair, system. And of course, the devil's in the details. Do we need one? Does a combination of just a few work well? Do you have to give one injection? Do you have to give multiple injections? There's a lot of type of pharmacology that would really need to go into optimizing it. But we were excited that about earlier this year, actually, a paper came out that looked at a mouse injury model of knee osteoarthritis. And they injected, it turns out, one of the microRNA that happened to be on that master list that I mentioned. I'm not sure if they recognize the fact that it's on the master list. I suspect not, but because they don't talk about that. But it not only slowed and prevented the injury-related osteoarthritis, it prevented the pain. So we not only do we not have anything that's a disease modifier, the disease modifiers that people are sort of have in development haven't really been all of that impressive in terms of their symptom modification. So the big conundrum in the field is, well, if you really have something that blocks the disease, shouldn't you be blocking the symptoms also? So that's
who'd have thunk it?
a major controversy.
Yeah.
Now we haven't seen that. So this is the first evidence I have seen of something that could do both. And to me, that spells truth, because if you're hitting both, that the cartilage degeneration and the pain are intimately related. So if you're able to turn the cartilage degradation off and repair it, you stop the symptoms. To me, that is the most hopeful sign I have seen in my career to date. That's giving me hope that there's a chance that we could get to a cure, if not, something that would be a limb regenerating, cocktail, maybe in another several decades.
Really, really amazing stuff. Coming back to you, though, we sort of typically wrap up the show with a couple more personal questions. The first sort of being around influencers in your career to date. Obviously, no doubt you've had the chance to meet a wide range of people over the years of your career. Are there any specific folks that you might want to give a shout out to that really kept you on this particular path, that, if it wasn't for them, you'd be doing cardiology or law or something totally else, that really said, at those times, obviously we know biotech has ups and downs, but that said, you're doing the right thing, stay with this?
I'm thinking back to medical school. So Duke has a really unique program where in the third year, the students go into the laboratory.
Nice.
So the first 2 years are really hellacious because everything is crammed into those first 2 years. But in the third year, you actually do bona fide either clinical or basic research.
Okay.
So I went into a laboratory that studied epilepsy, and Jim McNamara, who was my mentor, he always explained that if you want to be an expert in something and really help people, try to study it in the tissue culture dish, study it in the animal, and then develop methodology and take it into humans so that you can provide something really special. And so he was always a tremendous inspiration to me. And I think that the Duke system, which they still have today, of the third year, you are actually doing science, is really a remarkable opportunity. Because then, even you didn't know you love science, you could find out. Or you could find out, oh, I really think I really like, clinical instead. Or, oh, I think that I'm going to be a clinician full-time, which is great. But the clinician full-time who's done a third year of research views their clinical practice completely differently. It's much more evidence-based. They understand the literature. They've thought about statistics. So that was a very influential thing for me. And actually, I want to brag on one of my colleagues, and that's Bill Kalin. Please. So Bill Kalin is a medical school classmate of mine. And he won the Nobel Prize in Medicine this week. So I think he's also a product of this, having had the opportunity to go into the laboratory as a third year student and discover, wow, not only do I love this, but I'm really good at this. He's a brilliant man and deserves everything, that he got. So I really think that my shout out is to this kind of a system that offers the opportunity at a young enough age to see how you do. What do you think of it? And it has good benefits no matter what you end up doing. Absolutely.
There's a similar program, I think, down the street here in Philadelphia at Penn, where it's a special program where they, you can decide after, I think, second year medical school to try out the lab if you want to. But it seems like Duke's is really ahead of the curve there. So that's really neat. One last question, and this is you take your time with this one. This is the science fiction question. This has to do with the person that Dr. Virginia Krause would have liked to have met. It doesn't have to be. It can be a scientist, it can be a philosopher, artist, whomever it is. But if you had the ability to go in my time machine that I have it sitting in the other room here and travel and meet somebody that really inspired you from another time, who would that person be for Dr. Virginia Krause?
So that's actually a really easy question for me.
Okay, shoot.
And I see art on your wall, so I know you love art too. So
those are my daughters.
They're beautiful. They're just beautiful.
I like those guys.
For me, it's also art.
Okay.
So, as you know, well, science is a very challenging profession. One has to, be able to get the funding and keep, the projects alive. And it requires a lot of skills and a lot of different capacities and a lot of luck. And I think deep down inside, it's important to know for yourself that what you're doing is important and is going to be of help to the world. And that's what drives me. And the person that most inspires me to keep going and to maintain my perseverance is Van Gogh. Vincent van Gogh, for sure. He was a very, very spiritual man. And for people who haven't read about him or know that much about him, more and more is being understood about his life, who he was, the hardships that he endured. Deeply down, he knew, though, that what he was doing was extremely good. And his brother believed in him. And he kept going despite all the hardships and his health issues. But he would give the shirt off his back to anybody. And if I could go back and, encourage him, and if he could come forward and encourage me, I think that would really help. Because I really think that science, besides being a master chef, I think the more you see, and the more you look, the more you see. It's like an artist. And you develop something new. And I also have heard that when the Impressionists came about, they would try to send their work to the salon, the French salon, and typically it would then get carted off downtown through the town, and they would be embarrassed because it would have a big red R on the back of the painting that says refusé, which means it was refused, and so you're humiliated in front of the whole town. Deep down inside, you have to know that what you're doing is good and helpful. And they kept on going. So I think that for me, that whole era of art, and Van Gogh in particular, have been really inspirational, because I just think to myself, well, that's just the way it is. Eventually, the truth wins out. Just persevere. And that's true for this research that we talked about. And I think it's true for many, many scientists.
Absolutely.
Yeah. So if you could bring him back and I could talk to him, thank you for that.
We'll keep working on it. It's not peer reviewed yet, but I'll get it there. It's been really eye-opening and a fascinating conversation. And really, Dr. Krause, as we say on the show, it's all about moving the human story forward, and you're clearly doing that. And just a major thank you for everything you do for society and for the millions of sufferers out there. And clearly you're going to have the breakthroughs and really usher things forward in this next generation of products and interventions. And it's just amazing stuff. So really thanking you for that. And once again, for everybody watching, but also going to be listening on the various radio stations, we've been talking with Dr. Virginia Byers Kraus, professor of medicine, pathology, and orthopedic surgery, and a faculty member of the Duke Molecular Physiology Institute at Duke. She's also director of the Duke Biomarker Shared Resource and the director of the Molecular Measures Court, the Center for the Study of Aging and Human Development. Dr. Krause, thank you so much for taking the time to talk to us and join us and share your knowledge. It's been really fascinating.
Thank you so much, Ira.